Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today some more important rules that hopefully will help you take care of your patients. Rule number 186, consult with the mother or the caregiver in the room. So again, sometimes it's just best to explain the rule with a story. A few weeks ago, I was in the pediatric emergency medicine department and I saw a patient, and I honestly don't remember the exact story, but at some point I was a little worried that maybe this child is minimal change disease. To me, however, the child's face did not look swollen. He looks maybe a little chubby, but I didn't find any abnormalities, and I honestly don't remember what was it about the story that made me think about minimal change disease. However, at some point I turned to the mom and I asked, "Mom, does your son look swollen to you? Do you think his face is swollen?" She looks at him and she said, "Oh, actually, yeah, he does. Why do you think that, doctor?" I honestly did not think that. Something made me worry about minimal change disease. And at that point, although the child did not look swollen to me, he does look just a little chubby, I asked the mom. And when she said that, I knew very likely this child is minimal change disease. I asked her to show me a different picture of him on her cell phone, and lo and behold, yes, the child definitely has some edema of the face, and his urine was positive, and he does have nephrotic syndrome, likely minimal change disease. So sometimes it's very helpful to ask the parent or consult with the parent about their child. Another good example is when I think the child looks pale. However, again, it could be just a normal skin color. I ask the mom or the dad, "Mom and dad, does your son, your daughter look pale to you?" And if they say yes, I take that as physical finding. Patient is pale. Another good example for this rule is the patients with sickle cell disease pain or any other patient who presents with chronic pain to the pediatric emergency department. Very often I ask those parents, "Mom and dad, what medication helps your child the most?" Some kids with sickle cell pain crisis respond better to NSAIDs, some kids respond better to morphine, etc. So it's often very helpful to ask the parent or consult with the parent, the mother, the father, whoever is in the room, caring for the child, about what works for the child. Those of us who have used Versed for anxiolysis also know that some kids, I think it's about 10% of kids, have a very different response to Versed. They actually become hyperactive. So I often ask the parent, has your child ever gotten Versed or something called Ativan for procedures? What was the response to that? If the patient, according to the mother or the father, had a good response to anxiolysis, I'm happily giving it again. So remember rule number 186, consult with the mother or the parent in the room for your care of the child. Very often you can learn some very important details. Rule number 187, don't get the test that tells you what you already know. Again, always good to explain those rules with an example. So one of the things that drives me a little crazy is when the resident presents a patient that has mild abdominal pain, does not sound like a surgical abdomen, physical exam is inconsistent with the surgical abdomen, and then the resident says that according to the mom or the dad or the patient, he or she have not stooled in 5 days, and he would like to get a KUB to rule out constipation. My question to those residents is, why do you have to get a KUB to diagnose a condition you already know the child has? In other words, the child is not stooled in 4 or 5 days. He does not have a surgical abdomen. His physical exam is inconsistent with peritoneal signs or any other signs of surgical abdomen. Why do we need a KUB to show us stool where we already know, by definition, this child is constipated? Again, as a PEM physician, I think it's always important, very important, on any child with abdominal pain to rule out a surgical abdomen. Make sure the child has no peritoneal signs, no right lower quadrant tenderness, no red flags. And if the child has no red flags, has not stooled in 4 days, I don't think I need a KUB to rule in constipation. Maybe I need an ultrasound to rule out intussusception or appendicitis or, again, any cause of surgical abdomen, which is highly unlikely at this point. However, I would try to always avoid the test that already tells me something that I know by history and physical. Another good example for that rule is a CBC on a very well appearing child who has had fever for a few days and has cough, congestion, or symptoms of viral illness. Likely, the CBC will show some leukocytosis because the child has viral illness. I already know he or she have an infection. CBC doesn't really help me that much. You know this child is an infection, and the CBC is not going to change that. Again, getting a chest x ray to make sure the child does not have pneumonia, to make sure the child doesn't need antibiotics, is a helpful test. The same for a urine analysis ruling out UTI. But CBC on a well appearing child with viral like symptoms likely is not going to help. So don't get the test that tells you what you already know. Another example for this rule happened to me just a few days ago. Patient came in with mild vomiting and diarrhea, really did not look great, was a little pale and a little tachycardic. The kid was, I think, 4 years old and had a glucose of 66, which falls under maybe mild hypoglycemia. Patient received IV fluids, IV Zofran, looked much better, was having a popsicle and had something to eat about 2 or 3 hours later, and the nurse asked me if I want to repeat the glucose. In my opinion, on a child that is well appearing, had mild hypoglycemia, as now have had popsicle, eating, drinking, and looks back to baseline, I don't need a test to tell me what I already know. This child has drank, has eaten, is well appearing, has no tachycardia, and is back to baseline. I don't need a test to tell me what I already know. This child is very unlikely to be hypoglycemic. He was mildly hypoglycemic to begin with, and I see no reason to repeat the test that tells me what I already know. Along the same lines, I don't always get an ultrasound on a patient with a single, small, round, tender swelling on the cervical neck. In that setting of a runny nose, cough, congestion, what seems like a viral illness, likely the patient has lymphadenitis. If my concern for lymphoma is as close as it can be to zero, in other words, it's not a teenager, it's a single, small, mobile, tender lymph node, more consistent with inflammation, I don't always get an ultrasound. I know the ultrasound is going to show some cervical adenitis, and if I'm not going to change the management, I see no point to get an ultrasound, a test that takes 2 or 3 hours in the emergency department, to tell me what I already know. I think cervical lymphadenitis in a well-appearing child with a consistent history of a viral illness is not a necessary test. Sure, I highly recommend an ultrasound on a teenager who has cervical lymphadenopathy that is significant with several non-mobile, non-tender lymph nodes. That's a very concerning story for lymphoma. And under those circumstances, I think ultrasound may be even a standard of care. But I don't recommend getting an ultrasound on a very well-appearing kid with viral-like illness and a tender lymph node that is single, small, mobile, and inconsistent with anything concerning. So remember rule number 187. Don't get the test that tells you what you already know. Rule number 188. Don't try to be everything for everyone. You can never make everybody happy. Again, going back to a good story from the pediatric emergency department. So very often, and this happened just a few days ago, I get a child with vomiting, diarrhea, maybe mild dehydration. I certainly think that Zofran and a PO challenge is appropriate. However, I can tell from the mom's demeanor or the way she speaks and her concerns that she's very worried and she wants this child or will feel more reassured if the child gets IV fluids. Now, most of the time, I'm able to relate to the parent that Zofran is a very good drug, it's very beneficial, it's very helpful, and it's very effective, and I think the child will be fine with Zofran and some oral fluids. However, I always try once, and if I still think the mom or the dad are concerned and kind of requesting or think the child needs IV fluids, I do not hesitate. I ask the nurse to get an IV, give IV fluids. I take the advantage of that situation, check the electrolytes just to make sure, and I provide IV fluid for the child. Once the child is hydrated, I send the child home. Again, as always, make sure the vomiting and or abdominal pain is not secondary to a surgical abdomen. Now, sometimes when I do that, unfortunately, the nurse seems very unhappy. She agrees with me the child does not need IV, does not need IV fluids, but she might disagree with me about the management just for the sake of reassuring the mom. In my opinion, reassuring a parent is an important part of what I do. I can certainly see this mom comes back if the child vomits one more time or if she or The dad thinks he's still dehydrated. In my opinion, it's a very small price to pay. Get an IV, give IV fluids, etc. Sometimes, however, that makes the nurse a little unhappy. She now has to get an IV, she now has to give fluids, the child will stay in her care for several hours, but unfortunately, I cannot make everybody happy. Again, the medical management may be unnecessary, however harmless, and if mom or dad need IV fluid to get reassured, I think that's a very small price to pay. Yes, it may make the nurse or some other people in the ER who have to take care of this child for a longer time unhappy. However, I cannot make everybody happy. I need to make sure the child is safe, and it's in my best interest to make sure the parents are reassured so they don't come back tomorrow or in a few hours for the same concern. So remember, don't try to be everything for everyone. Sometimes you can reassure the parents, but that has a cost of maybe keeping the child in the ER for longer, which may make some of your colleagues or your nurses unhappy. Nonetheless, it's worth doing. Go to the nurse, explain to the nurse what and why you're doing what you're doing, and hopefully you'll get him or her to agree with you. But don't try to make everybody happy. It's just never going to work. And that is it for today, guys. Thank you very much for listening to PEM Rules. Thank you for all the feedback and all the rules and ideas you've given me. I truly appreciate it. Let's review briefly what we learned. Rule number 186. Consult with the mother or the caregiver in the room. If you don't think the child is pale, but you're concerned about it, ask the mom or the dad, does the child look pale to you? If the answer is yes, take it into consideration. Rule number 187. Don't get the test that tells you what you already know. Get a good history, get a good physical, and if you have no concern for a surgical abdomen, the patient has not stooled in 4 days, he or she look well, you can make the diagnosis of constipation without actually getting a KUB. As always, remember, it's not the patient's job to prove that they're sick, it's your job to prove that they're not. In the setting of abdominal pain and maybe GI symptoms, make sure there's nothing in that history or physical that are concerning for surgical abdomen. Rule number 188, good rule for life, don't try to be everything for everyone. You can never make everybody happy. Sometimes you have to do something for the patient that may make your colleagues unhappy, may make the kid stay in the ER longer, may make the nurse unhappy, whatever it is. If you feel that needs to be done, even just for the sake of reassurance, go to the nurse, explain why you're doing what you're doing. You can even apologize. However, don't send the mom worried home. That is never a good idea. Don't try to be everything for everybody. Try to explain your reasoning and explain your actions. Do your best and move on. And that is it for today, guys. Again, thank you for listening to PEM Rules. I hope you like the rules and use them in your clinical work. The following outro is one of my favorite songs by Metallica. It's called Until It Sleeps. Not one of their big hits, great song nonetheless.